Good evening. I think I'm the very last speaker, so I'll try to make this fast. Okay, so I'll go straight to the case. This is a full-term newborn born at an outside hospital, noted to have persistent hypotonia with suspected HIE or hypoxic ischemic encephalopathy. So a request was made to transfer this baby to UCLA for cold cap hypothermia therapy. A little bit of pregnancy history. 29-year-old G2P1 mom did have a significant history of seizure disorder, about 2 seizures per week, on 2 drugs throughout pregnancy. So she was on trileptal and lamictal treatment. All prenatal labs were normal, and mom actually noted decreased fetal movement, especially during the last month of pregnancy. Fetal monitoring in the 1 month prior to delivery was normal at an outside OBGYN office. Ultrasound at 5 months showed some nuchal thickening, and amniocentesis was normal. A little bit of birth history then. Nuchal cord times 1 was noted. There was some paleness, poor respiratory effort. There was a few gasps noted and was apneic. This baby was apneic by 1 minute of life. PPV via bag and mask was started. An ET tube was inserted. Heart rate was 110. There was poor chest rise in spite of bilateral breath sounds. And this baby was brought to the NICU by 3 minutes of life. The baby was extubated because of the poor chest rise and basically re-intubated successfully a second time. Required some epi and normal saline boluses, some chest compressions for low heart rate while establishing the airway. APGAR scores were 3, 3, and 4, and there you have the initial blood gas. And again, this baby was transferred to the UCLA for the cold cap hypothermia treatment. So the first question then is, at this point, before even seeing the baby, what tests would you like to order at this point? CBC with manual differential, CSF exam for routine labs, CSF for glycine, lactate, or viral cultures, an EEG, or a head ultrasound. So 36% picked EEG. Okay, let me move on and we'll get our answers pretty soon. So this baby underwent 72 hours of head cooling according to the UCLA protocol. The initial exam at UCLA was significant for contractures in all extremities, very smooth skin on palms and soles, globally decreased tone and responsiveness, but the pupils were reactive. Occipital lobe seizures were noted on EEG, and this baby was treated with Keppra. And a head ultrasound on day of life 2 did not show any intracranial hemorrhage. So with that information, exam, and continued hypotonia, what other tests would you order at this point? Looks like all of the above is the correct answer. So MRI, MRA, and DWI was done on day of life 5. Showed possible hypomyelination, but really very, very mild if indeed there. MRI and MRS on just about 8 days later showed some ventricular enlargement, no definite signs of HIE. There was very minimal lipid and lactate peaks, and CSF exam was quite difficult at many points in time due to sedation with this baby. As well as concurrent pneumonia. On day of life 18, we got a much better exam. And so the exam was significant for spontaneous eye opening, good tracking, still with global hypotonia, tongue fasciculations were noted, and no deep tendon reflexes. And an EMG was done on day of life 20. I'll share with that in just a little bit. On the metabolic and genetic side, there was initial metabolic acidosis. CGH was sent on day of life 3, and just basic screening labs on amino acids and urine organic acids were also sent. Respiratory status-wise, baby was ventilator dependent for the entire duration of the hospital stay. Baby was treated for GBS pneumonia. with ampicillin gentamicin and a lumbar puncture on day of life 13. You see the values there. So at this point, the next question is, which category of diagnosis is the most likely? 53% picked neuromuscular condition. Great. So I'm going to talk a little bit about neonatal hypotonia. So as you can see here, this is a very wide open localization. Hypotonia really can present at any level of the neural axis. So you have the central hypotonia, which includes HIE, some of the metabolic and mitochondrial disorders, chromosomal abnormalities. But moving down the neural axis, you can certainly have something in the cervical spinal cord, you can have something in the anterior horn cell, and then neuromuscular junction, as well as myopathies. So some of the important clues in this case is that the mom recounted the lack of fetal movements, despite lack of evidence for fetal distress upon monitoring. That there was the respiratory distress without discernible pulmonary pathology, including flaring chest wall, very alert, full extraocular movements, tongue fasciculation is a key one, as well as absent deep tendon reflexes. And so again, these are some of the localizations. We'll start on the top. So some of the central causes, we'll just go through quickly and try to rule out or rule in the different diagnoses. So first of all, acute HIE, which was what the outside hospital thought. Congenital cerebellar syndromes, kernicterus, chromosomal abnormalities including Down or Prader-Willi. And certainly, again, metabolic syndromes. They can all cause central hypotonia. But really, none of these categories or diagnoses should pose a challenge to extubating this baby. And so here's just a diagram to show you that not only should we consider gray matter injury, but certainly white matter injuries, such as in PVL, as well as subcortical structures or the basal ganglia injury, which can be seen in HIE as well as kernicterus. So really all of this is less and less likely. So this is actually our MRI of the patient. So there's really nothing in the basal ganglia, really nothing in the cortex or parenchyma. And at the bottom, you see the MRS, which was also read as normal. Again, more MRI pictures. And on the right is the DTI, showing very symmetric and normal appearing white matter tracts. And so this is the official interpretation from our neuroradiologist. And we mentioned that there were some seizures noted. So there were multiple subclinical seizures, so not just one or two, all in the initial days of recording. For whatever reason, over the right occipital region, but subsequently seizure-free on Keppra therapy. So the EEG, although it showed a seizure and may suggest central etiology, it did not show severe voltage suppression suggestive of HIE. It did not show a suppression burst pattern, which has been documented also in HIE. And again, episodic, early, seizure activity and being treated on levetiracetam really should not cause a problem with extubation. So, so central etiologies are basically not very likely at this point. So let me move on to some of the localizations further down. So another picture, so anterior horn cell is another site, peripheral nerve certainly, neuromuscular junction, as well as, again, myopathies. I'll start with the muscle site first. So congenital myopathies is certainly one category to consider. Babies often present with hypotonia, hyporeflexia, facial paralysis, which is really not the case here, ptosis, which is really not the case here, and high arched palate. Slowly progressive condition is usually what we see. Biopsy shows structural changes, but not dystrophic or destructive changes. And then Nemolan central core myotubular and congenital fiber type disproportion are the different subtypes under congenital myopathies. So let me go back. So because this baby really did not have facial paralysis or ptosis, the entire category of congenital myopathy is not very likely. What about congenital muscular dystrophy then? So another muscle problem. It's a heterogeneous group of disorders. In the neonates, at least, it often involves muscle, brain, and eye. Can be seen with arthrogryposis. And some types, including the Fukuyama and Walker-Warburg types, can involve cerebral malformations. So you could actually have both central and peripheral. The biopsy in congenital muscular dystrophy, which, as the name implies, show dystrophic changes or destructive changes, which differentiates these diseases from the congenital myopathies. And then just about half of congenital muscular dystrophy may be due to myrosin deficiency. So this is just an example of Walker-Warburg syndrome, characterized by hydrocephalus, agyria, and retinal dysplasia. Again, a variable group of autosomal recessive disorders. The common clinical presentation is weakness, hypotonia, and again, abnormal muscle biopsy. Muscle weakness is generalized and often involves bulbar muscles and facial weakness. So again, this baby really did not present with bulbar problems or facial weakness. So that pretty much rules this category out. This is just a picture just to show you how complicated the muscle membrane could look like and where the various problems could lie. Another consideration then would be congenital myotonic dystrophy. So this is autosomal dominant on chromosome 19. It's a CTG repeat expansion of the DMPK gene. There is genetic anticipation. So what we often see is a floppy infant with a hollow temporal fossa, tented mouth, cataracts, and a mental retardation. The EMG of the mother shows the myotonia, and CPK may not be elevated. And this baby is pretty classic for congenital myotonic dystrophy. So moving on to the next localization, neuromuscular junction. So there's many forms of myasthenia gravis that's worth considering. So different forms, so the first one to talk about is acquired neonatal myasthenia gravis. It can be present in about 10% of babies born to mothers with myasthenia gravis. It can be present at birth with generalized weakness and hypotonia. Again, there's bulbar weakness, which is not present in this baby. Reflexes should be normal, and diagnosis confirmed by a challenge with edrophonium or neostigmine, and usually resolves within 6 weeks. So again, not very likely in this child. Congenital myasthenic syndrome then, which is different from acquired, is caused by pre- or postsynaptic inherited defects of neuromuscular junction. It's very, very rare. It's basically a group of genetic disorders that are acetylcholine receptor antibody negative. So again, congenital malformation of the neuromuscular junction. Other causes which are not so relevant here is hypermagnesemia, aminoglycoside toxicity, hypocalcemia, and infantile botulism. But these are all neuromuscular junction blockade as well. So of then the myasthenic syndromes, neonatal, so acquired one, congenital, and then there's actually a juvenile one that's very, very similar to adult myasthenia gravis. So really the only one to be considered is the congenital one, and even that is really not likely because you don't expect fasciculations of the tongue as we saw in this baby. And then moving on up the neural axis then, hereditary motor and sensory neuropathies. Probably the most well-known one is the Charcot-Marie tooth. But those tend to come much later in life. There is a dead ring sotas version which can be present in the neonates. But again, you would not expect the fasciculation of the tongue. So then that leads us to SMA, or spinal muscular atrophy. 3 different types in broad categories. So type 1 is often called Wernicke-Hoffmann, type 2, and then type 3, which is often called Kugelberg-Wieslander. At least in the type 1, the infants are often in frog-leg posture, severe hypotonia on traction and ventral suspension. There is sparing of the extraocular muscles, which is the case in this baby. Tongue fasciculation certainly is very, very characteristic, and it's an autosomal recessive disorder, predominantly affecting the SMN1 gene. Clinically, they present with severe flaccid paralysis, worse in the proximal and the lower limbs. So you could actually see subtle finger movements, but not proximal movements. Decreased fetal movement often reported by the mom, weak respiratory muscles, poor suck and swallow, weak cry, again, tongue fasciculations, and absent reflexes. And there should be sparing of upper cranial nerves in SMA. So this is a disease of degeneration of anterior horn cells in the spinal cord. EMG shows abnormal spontaneous activity with fibrillations and positive sharp waves, consistent with denervation, which is actually the pattern that was found in this baby. Serum CK is normal or slightly elevated, so not very helpful when it comes to helping you with diagnosis. Biopsy shows groups of circular atrophic fibers interspersed among hypertrophied fibers, as you see here. And oftentimes, you can bypass the EMG and the biopsy with a gene test nowadays. And it tests for SMN1 and SMN2, which stands for survival motor neuron. So a little bit of genetics of SMA. It's the most common mutation seen in 95% of individuals with SMA. It's usually a deletion of exon 7 of SMN1, which is the telomeric SMN, on chromosome 5q. There is actually another version, which is centromeric, which is SMN2. It's identical in sequence, but is quite different in post-transcriptional splicing. So it yields only a functional protein in about 10% of the time. So the number of copies of SMN2 really helps determine the functional and the prognosis of these babies. So you would expect the SMN2 to have lower copies of SMN2 in the most severe cases, as in Wernicke-Hoffmann, and then more of SMN2 in the less severe cases. So our patient ended up having 0 copies of SMN1 and only 1 copy of SMN2. So this is a severe form of SMA, and again, Wernicke-Hoffmann. And that's why the presentation was so early, right after birth. So just to give you a little bit of what happened to this baby, Becker array was completely normal. The plasma amino acids and urine organic acids was not suggestive. EMG again showed motor axonopathy or neuronopathy. And we just talked about SMN1 being, having 0 copies for this child. And a discussion was held with the parents regarding the poor prognosis of SMA. So they decided to transition to comfort care and to withdraw support. And just the last slide to talk a little bit about treatment. There's really no treatment, certainly no cure at this point. All treatment is really supportive. But a lot of people have been really interested in finding a treatment or a cure, given how bad the prognosis is in SMA. So one of the first ones to be tried was Depakote. It was shown to increase SMN2 transcription overall in animal studies. but when it was actually run in human clinical trial, there was no clear improvement. There was actually then another trial with sodium phenylbutyrate. This is actually a drug for urea cycle disorders. Again, in animal studies, shown to increase SMN2 transcription. Unfortunately, it did not have enough enrollment, and the study was terminated. And then lastly, which is probably the most exciting trial right now, is an antisense oligonucleotide trial. It is meant to sort of trick the cell into including exon 7 in SMN2 so that the protein that is made is actually functional. And so this is actually in clinical trial right now, and this is something that has to be administered intrathecally.